Good evening to everyone present here with us today. This is Shreyon from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Panchanan Sahu. Sir is the MBBS, MD Medicine, DM Cardiology, FACC, FECS, FICC, FISC, Interventional Cardiologist, and Electropsychologist at Kalinga Institute of Medical Science in Bhubaneswar. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is hypertension guideline. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you, Madam. I welcome all viewers and I am thankful to the team of Indian Journal of Clinical Practice for bringing this opportunity to talk to the team of the general practitioner, the physicians or cardiologists on this topic, hypertension guidelines, with special reference to Indian Society of Hypertension Guideline, which came in this year 2023. So before going to the actual topic of hypertension guidelines, I'd like to speak few words. Not changing.
No, sir, your slides are not changing.
Slide not changing. It was changing initially.
Yes, sir. Earlier it was changing. So just exit the full screen once.
This is full screen. I'll escape
exit
and
it. Exit that full screen.
What has happened? Something to computer.
So just click on
yes,
sir.
So before going to the hypertension guidelines, I'd like to speak talk on few words about the history of hypertension. It goes back to the era of Sushruta Charak. Charak was the physician who told the systolic blood pressure attained during the contraction of the heart is controlled by some Vata, Gyan Vata, Jnanabhata, Vata. Like Vata Pitta, he told that during contraction, blood goes. And the second most important, William Harvey, we know, who discovered circulation in 16th era, who talked on the cardiovascular system and blood flow due to the pressure of the circulation, blood circulation. And Stephen Hales, who first started BP measurement in way back in 1733, and the Stephen Rivorosi, who in 1896 first started cuff-based sphygmomanometer measurement. And the well-known Nikolai Korotkov, who discovered the Korotkov sound in 1905, discovered Korotkov sounds which we hear during our blood pressure measurement. And in 1911, Bernard Frank, he described elevated blood pressure, hypertension first time. So the hypertension guidelines, when we just discuss in our knowledge from our student days or before 3 decades, we will only talking about JNC recommendations, Joint National Committee on Hypertension recommendations, which started in 1977, and just from JNC 6 in 1998, JNC 7 in 2004, and JNC 8 in 2013. And JNC 8, we still were following the recommendations. Besides other groups like United States of Preventive Service Task Force, American College of Obstetrics and Gynecologists, Department of Veteran Affairs. They give some recommendations. Very important, the European Society of Hypertension and combined with the European Society of Cardiology have given recommendation 2008 and 2023, and American Heart Association and ACC, American College of Cardiology, have given recommendation 2013, then 2017. So the blood pressure threshold of different guidelines. So important 4 guidelines I have shown here. The earlier the European Society of Hypertension, American College of Cardiology, International Society of Hypertension, and just came recently in the 2023, the Indian Society of Hypertension guideline. The in all the 4 guidelines, if you decode and analyze, so in American College of Cardiology guideline 2017, they have decreased the threshold, the normal making below 120 and elevated 120 to 130, stage 1 hypertension 130 to 130, and stage 2 above 140, they have made stage 2 hypertension and treatment starting at 130. But if we look to the International Society of Hypertension guideline and Indian Society of Hypertension guideline, it is more alike. In Indian guidelines, optimal less than 130, which is made normal in international guideline less than 130, high normal 130 to 139, and grade 1 hypertension 140 to 159, and grade 2 above 160. Similar is the International Society of Hypertension guideline. And the European Society of Hypertension has divided more optimal below 120, normal 120 to 130, high normal 130 to 139, grade 1 140 to 160, and grade 2 above 160, 160 and 170 up to 179, and grade 3 above 180. Besides this, isolated systolic hypertension when systolic more than above 140, diastolic below 90, or isolated diastolic hypertension also described when systolic below normal, the diastolic goes above above 90 millimeter mercury. As described JNC 678, which we are following JNC 8 from 2013 onwards. Here, already I have told the normal below 120, pre-hypertension they describe 130 to 139, and anything above 140 by 90 is told as hypertension. Stage 1 is 140 to 159 and 90 to 99 diastolic, and stage 2 above 160 systolic and above 100 diastolic. Besides, it has been added above the age of 60 years, the threshold is above 150. So up to the age of 60 years, less than 150 systolic is normal. And 140 is the target below 60 years. And just to bring notice of JNC 6 and 7, JNC 6, they have made stage 1, stage 2, and stage 3 hypertension. Stage 1, 140 to 159, stage 2, 160 to 179, and stage 3 above 180. And JNC 7 has made these 2 stages. Normal less than 120, pre-hypertension 100 to 130, stage 1 140 to 159, stage 2 1 more than 160. So what is the threshold for diagnosing hypertension? Just have showed here. In a clinic and a home. In ACC, it is less than 130 by 80. ESC, International Society of Hypertension, and Indian Society of Hypertension, 140 by 90. Up to then, after 140 by 90, we start treatment. And the home blood pressure, ACC, 130 by 80, and the ESC, International Society and the Indian Society, less than 135 by 85. And in ABPM also, daytime, nighttime, daytime 130 by 80 ACC, 110 by 65 nighttime. But in others, the daytime blood pressure 135 by 85 and night 120 by 70. So in the guidelines, the management of hypertension, which I have highlighted more with giving more emphasis of in the Indian Society of Hypertension guideline. So the treatment of hypertension just have Indian Society of Hypertension 2023 and the European Society of Hypertension 2033 more alike. Grade 1 hypertension lifestyle intervention, and then we start along with lifestyle hypertension. Two drugs, ARP or calcium channel blocker, or ACA with calcium channel blocker. And grade 2, we go to combination therapy, and when hypertension mediated organ damage we find, we go to combination drug therapy. And in the European Society of Hypertension, they have made stage 1, stage 2. In stage 1, start with the lifestyle modification, SC or ARB with calcium channel blocker or a diuretic. And stage 2, SC or in ARB plus calcium channel blocker plus diuretic. And in the resistant hypertension, all three drugs along with the beta blocker is added. So the initiation and choice of antihypertensive drugs, just have shown here the choice of drug in SCC, diuretic, calcium channel blocker, SC inhibitor, or ARP. Then in International Society of Hypertension, start treatment above 140 by 90. And in Indian Society of Hypertension also drug treatment above 140 by 90. And the start of drug with a diuretic, calcium channel blocker, SC inhibitor, or ARP, or beta blocker when it is indicated. The target for blood pressure in different guidelines I have shown here. The target will be ACC slightly less, 10 millimeter less, 130 by 80. But in International Society of Hypertension, the target less than 140 by 90. European Society less than 130 by 80. And Indian Society of Hypertension target less than 140 by 90. But when associated with target organ damage like hypertension with the coronary artery disease, hypertension with the cerebrovascular accident, hypertension with the heart failure, with CKD, or hypertension with the diabetes, the target is 130 by 80. Then with certain comorbidity along with the hypertension, the lifestyle change is more important here besides the drugs for blood pressure management. And the BMI, ideal BMI, as you know, 18 to 22.9, normal BMI. Less than 18 underweight, and overweight is 23 to 24.9. And the pre-obese, we tell 25 to 29.9 or 30. Type 1 obesity 30 to BMI 30 to 40, type 2 40 to 50, and type 3 super obese more than 50, BMI more than 50. Besides, in obesity, other important waist circumference in men above 90 and women above 80 is obese and should be decreased, and waist hip circumference in a men should be less than 0.9 and in women less than 0.85. So the approach to treatment in obesity, lifestyle change, dietary restriction should take on more of complex carbohydrate along with the protein, vegetables, more roughage and fruit, and moderate exercise in cases of obese. In normal, we tell 150 minutes per week or at least 30 minutes per day. In obesity, we recommend moderate exercise, 60 minutes daily or 300 minutes in a week. And the drugs S inhibitor, ARP, calcium channel blocker are preferred. Besides diuretic and beta blockers, because they affect blood sugar and cholesterol, these are kept to the second line. Besides, important bariatric surgery has been recommended those above BMI above 37, and those are morbid obese, gastric binding, gastrectomy, RNY shunt, RNY gastric bypass has been recommended. Those who are morbid obese. Besides, with the comorbidities, hypertension with the diabetes mellitus, very important group because hypertension is twice common in diabetic than general population. Patient with both hypertension and diabetes harbor higher prevalence of isolated systolic hypertension, and they behave non-differs. And in hypertension with diabetes, most important is a lifestyle measures. Salt should be taken less than 100 milligram per day. Weight reduction necessary to maintain an ideal body weight, ideal body mass index. Besides, diet rich in fruits, vegetables, and low fat should be taken. Regular exercise, as I mentioned, at least 30 minutes per daily with 150 minutes per week. Smoking cessation is very important, and moderation or curtailing alcohol intake is very important. Besides hypertension and diabetes, the target BP less than 130/80 and should be less than 540 in elderly patients. The pharmacotherapy initiated above 130/80 uh, and initiate with the monotherapy S inhibitor or ARP or calcium channel blocker thiazide in the presence of microalbuminuria, initiate therapy with the S inhibitor or ARP. And if BP remains more than 20/10 millimeter above the goal, then a long-acting non-dihydropyridine like delciam verapamil should be added as they decrease albuminuria. Besides hypertension management diabetes in patients with the recent MI, beta blockers should be added. Carvedilol is preferred over metoprolol. Avoid combination of SC inhibitor and ARB. They should not be combined together. Either SC inhibitor or ARB or ARNI is used. This increases the risk of because the SC inhibitor ARB combination and they increase risk of hyperkalemia. And for primary prevention, a statin may be included in the treatment regimen. Always a statin should be included in the treatment regimen of diabetes with or without hypertension. And drug therapy of coronary artery disease, I have told the compelling indication is a beta blocker. And for blood pressure, SC inhibitor or ARB should be added. Beta blocker, either a metoprolol, bisoprolol, carvedilol. Now it is carvedilol preferred. Bisoprolol is most specific, also equally good. Calcium channel blocker, amlodipine or verapamil used. Besides, statin is its indication either it is SCS with post-MI or post-PTC according to the dose is adjusted. Nitrate should be added, and lifestyle changes, stopping smoking is very vital. And in a heart failure drug therapy, 1% of total population belong to heart failure group. And the important studies which revolutionized treatment, the paradigm in heart failure treatment, which brought ARNI and DAPA heart failure in HFrEF, heart failure with reduced rejection fraction, ARNI decreases 20% death and 21% reduction in heart failure hospitalization. Besides, in the heart with the heart failure with the preserved ejection fraction, EMPER or preserve deliver F trial have established drug treatment. SC inhibitor, ARNI, SC inhibitor, ARB, beta blocker, calcium channel blocker, diuretics. These are important in the heart failure management. And arterial fibrillation group, 1/3 of the general population have blood pressure, 5.1% rural west in Western India. The smart monitoring of arterial fibrillation real time in India study hypertension common risk factor in arterial fibrillation. And the drugs SC inhibitor, ARP, beta blocker, diuretic, antiarrhythmic drugs should be added. The non-pharmacological treatment like yoga, pranayam, dietary restriction, exercise, isotonic exercise should be followed because isometric exercise increases the blood pressure and lifestyle changes, alcohol moderation is vital. Then hypertension mediated organ damage, it is very important to detect and treat. Hypertension mediated damage can occur with a less severe hypertension, even if may be found even first time presenting with hypertension and severe hypertension. Specific organ correlations of in heart, LVS, heart failure, in CKD, the renal parameters should be tested, retinopathy should be, ophthalmoscopy should be done. And the investigation in the cardiovascular system, ECG, echocardiography, and carotid intima media thickness, pulse velocity record, peripheral vascular Doppler, all these are important. And in the renal urea creatinine, eGFR calculation, urinary albumin creatinine ratio, cystatin C endoscopy should be included. Drugs inducers of hypertension like alcohol, caffeine, cocaine, nicotine, recreational drugs, they increase blood pressure, sodium, increase sodium intake, increase blood pressure, smoking, non-steroidal or anti-inflammatory drugs, calcineurin, cyclosporin, increase blood pressure, anti-cancer drug, hormone for menopausal women, ritodrin for premature labor, all these increase blood pressure. So the drug choice in special groups, different special group already I have told. The like coronary artery disease, cerebrovascular accident with heart failure, with CKD, with diabetes mellitus. In the 4 group, the drugs I have shown here already described. The emerging role of beta blockers is very important. As we know, the place of beta blocker has been restricted back, particularly in the SEC guideline. But other guidelines have improved the role of beta blockers has been brought forwarded. So the mechanism of beta blocker depress sympathetic nervous systems, decrease heart rate, blood pressure, decrease cardiac contractility. American College of Cardiology does not recommend usage of beta blockers as first line therapy. SEC does recommend the usage of beta blocker only severe ischemic heart disease. All three other guidelines, the International Society of Hypertension, Indian Society of Hypertension, European Society of Hypertension, all these recommend beta blockers as first line. All three guidelines mention the list of indications I'll describe. So the baseline heart rate between 18 to 55 years, when more than 82, beta blocker, if heart rate more than 80, should always be considered. Besides renal failure, the other indication, the coronary artery disease, acute coronary syndrome, chronic coronary artery disease, coronary syndrome, post-myocardial infarction, heart failure with ischemic heart disease, we should add beta blocker, arterial fibrillation in control of heart rate, and prevention of arterial fibrillation should be given. Then pregnancy hypertension, women with childbearing age, thyrotoxicosis, obstructive sleep apnea, COPD, postural orthostatic tachycardia syndrome, postural hypertension, orthostatic hypertension. Then besides hypertension, emergency, and perioperative hypertension should be treated with a beta blocker. So the beta blocker indication has been extended. Besides, in CKD, stage 1 to 3, when EGFR more than 30, beta blocker along with the spironolactone centrally acting drug should be added. And those who are in stage 4 and 5, EGFR less than 30, chlorothalidone should be added. Beta blocker, chlorothalidone, and central acting drugs should be chosen for hypertension control. Besides hypertension in pregnancy, all four guidelines breaks down the hypertension in pregnancy into pre-existing hypertension, gestational hypertension, superimposed preeclampsia, and unclassified hypertension. So the while European Society, Indian Society of Hypertension, International Society of Hypertension define gestational hypertension after the age of 20 weeks and resolve within 42 days postpartum. But no such recommendation or guideline is there with the ACC. Drug treatment mentioned broadly remains the same in the four guidelines. So it is important after age of 20 weeks when blood pressure hypertension find it is pregnancy hypertension and should resolve within 42 weeks, 42 days postpartum. So what are new horizons in blood pressure control as mentioned in the Indian hypertension guideline? Telemedicine has been very important as we have found in the COVID time. Also telemedicine helped a lot. Mobile communication and mobile app application has been very helpful in blood pressure control and regulation management. Besides artificial intelligence and the digital device, artificial intelligence has been very important, and digital device, Android digital speed movement meter has been used in home blood pressure measurement also. So this is in nutshell about the guidelines, four important guidelines besides JNC, Indian Society of Hypertension, International Society of Hypertension, European Society of Hypertension guideline, ACC guideline. All these have given recommendations, but every patient is different, and we have to take into account the presentation and what are the comorbidities of the patient. Accordingly, we should choose our drugs, but lifestyle change always should be started fast along with drug therapy. Thank you. Am I
Thank you
audible?
so much. Yes, sir. Thank you so much, sir, for your wonderful presentation. So, sir, we have few questions from audience if you like to take that up. So, sir, the first question from our audience is, how do you approach individualizing hypertension treatment based on patient characteristic and comorbidities?
Yes. So already I have mentioned it is very important to individualize the patient. The when the hypertension starts and what are comorbidities associated at that particular moment. So in a young patient with there's a baseline heart rate is higher side 90, 100 like that. A beta blocker can be the fast drug also. But when associated comorbidities like a coronary disease, it is a compelling indication for a beta blocker. Although we use for hypertension, AC inhibitor, ARB, uh, a certain naturally we choose. And we can add diuretic when it is not controlled with the single, usually two drugs started, not two drugs. With the two drugs, we can add a diuretic. And when there is a heart failure or arterial fibrillation with a higher rate, we can add this diuretic along with our beta blocker. So, according to the comorbidity, if it is a CKD, as I have already mentioned, those GFR above 30, we add spironolactone. Those GFR stage 4-5, we add a chlorothalidone along with the beta blocker and the central acting drugs for CKD. So, according to the patient age, besides in pregnancy hypertension, I have mentioned the beta blocker use has been used, and the drugs chosen according to the presentation. Labetalol has been very helpful in orally or with accelerated hypertension parenteral use.
Thank you so much, sir. So, the next question from our audience, sir. Can you share a challenging case where you had to trail your hypertension management strategy due to unique patient circumstances?
Yeah. The compliance of the patient is very important. I have faced patient taking already 4 drugs, and along with that, when I asked, is he taking a regular NSAID use or non non-steroidal anti-inflammatory drug? And another patient I have faced whose his salt intake is high. So compliance of the patient and any drug he is taking or extra salts he is taking, which can present like acid hypertension or some patient present with the after aged patient, elderly patient, isolated systolic hypertension, not controlled with a single drug. In those patients, we find out their combination chemotherapy which will help. And that individual patient, we have to decide why there is a resistance or there is a no good control. Is it a lack of compliance or any associated condition which is increasing the blood pressure?
Thank you, sir. The next question from our audience is, what strategies do you find most effective in managing resistant hypertension?
Already in the process, I have told resistance hypertension will tell when there are we are using only 3 drugs, one of which diuretic, and we in those cases resistance hypertension. Many renal CKD patients we find resistance to drugs. So in the resistance hypertension, most important is the compliance of the patient we have to see, and I have showed some conditions, uh, drugs inducers of hypertension. This slide has been. So if alcohol, caffeine intake, nicotine intake, the more of salt intake, smoking, non-steroidal anti-inflammatory drugs, and then drugs like anticancerous or immunomodulator, cyclosporine, which can increase the blood pressure. Certain anti-cancerous drugs also, like cyclosporine, they increase blood pressure. This besides hormone therapy in women, that also can increase the blood pressure. Retardant for premature labor. All these drugs also increase hypertension. So the while considering the resistance, any associated drug, non-compliance of the patients, and and hyperaldosteronism, any endocrine hypertension or secondary hypertension if associated, should be taken care of while treating a resistant hypertension.
Thanks, sir. So the last question from our audience is, are there any emerging technologies or innovative approaches that you believe will significantly impact the diagnosis or treatment of hypertension in near future?
So the diagnostic modality, beside the standard, as I've already mentioned, for cardiac parameter, ECG, echo, CT, cardiac MRI, for renal function, already I mentioned the besides urea, creatinine, EGFR calculation, and the newer investigation, suppose it is CT, adenoid tumor hyperaldosteronism. All these by CT or the hormonal assay, which can give diagnosis. And in a treatment side, the drugs and for hyperkalemia, besides the potassium binding regimen, Finland drug, newer drug have come, and besides the uh, renal artery RF radiofrequency ablation has been implemented. The initial studies, there was some setback, but selective patients can get benefit.
Thank you so much, sir, for answering all our questions, sir. Before concluding today's session, sir, any last remark from you?
So the lifestyle change is the most important in the management of hypertension. And always, it may be stage 1, it may be stage 2, it may be isolated systolic hypertension. The lifestyle changes, lifestyle modification is the most important. So, diet control, regular exercise, weight reduction, ideal weight management, and the pressure, mental anxiety, stress also has become in a modern life one important thing which increases the blood pressure. So the along with our lifestyle change, regular relaxation, may it be in the work field, in the professional field, some relaxation is needed to keep your blood pressure in good control. Regular exercise, diet control, moderation of the alcohol, these are very important. So lifestyle change is very important in controlling blood pressure, keeping a optimal or normal blood pressure. So along with the drugs, if uh, already we have discussed, if there is a resistance, we have to find out the cause why there is a resistant hypertension. Even you were asking example, one patient, he had the coarctation of aorta was there. So the upper limb were hypotensive. We are treating without diagnosing for a long time the secondary hypertension. When diagnosed by approaching the coarctation of aorta, the hypertension could be controlled. So any associated secondary hypertension must be considered while treating or getting resistance in treatment of hypertension.
Thank you, sir.
Thank you.
Thank you, sir. Thank you again for joining us today, and thank you for this lovely session.